Go ahead and proceed though. So good afternoon, everyone. For the record, this is Steve Shell, Vice Chair of the SURG Treatment and Recovery Subcommittee. I will call this meeting to order and turn it over to Kelly to conduct our roll call to establish our quorum.
All right, Assemblywoman Thomas.
Here.
Chelsea Cheatham. Dr. Dixon.
Here.
Lisa Lee. Steve Shell.
Here.
Jeffrey Iverson. So, Mr. Vice Chair, we are lacking a quorum. We need one more member, and if another member joins us, I will pause process to let you know that we have a quorum.
Great, thank you, Kelly. So it sounds like we could jump ahead to agenda item number 4. Is that correct?
So, Rosalie, should we go with the presentation as is and like ask for public comment, or should we go straight to the presentations?
I mean, it can't hurt to take the public comment, but because this isn't technically a meeting, there isn't as hard and fast requirements, but like I'm always an advocate of take all the public comment you can. So it couldn't hurt to go ahead with it. Though I would say if you reach a quorum, we might need, I mean, you could also hold off because if you reach a quorum, that'll be the beginning of the meeting and you'll need to take public comment then. So you can kind of do it as you like. You could take both or you could do either, but I would say if at the point that you reach a quorum, you'll need to treat it as the start of a meeting.
And I see we have a question from Dr. Dixon.
Actually, it's public comment
Oh,
because I'm not sure I should really say this.
Would you like to do it now, or if they reach a quorum, would you rather make it to a quorum later?
No, I'll do it now. It's just a piece of information.
All right, let me, Dr. Dixon, just for a moment, let us do our then meeting approach, and then you can proceed as indicated by the Vice Chair. So, Mr. Vice Chair.
okay. So Steve Shell, for the record, we will move on to agenda item number 2, public comment. I will read a statement for the public. So public comment will be received via Zoom by raising your hand or unmuting yourself when asked for public comment. Public comment shall be limited to 3 minutes per person. This is a period devoted to comments by the general public, if any, and discussion of those comments. No action may be taken upon a matter raised during a period devoted to comments by the general public until the matter itself has been specifically included on an agenda as an item upon which action may be taken pursuant to NRS 241.020. And now I will turn it over to Kelly Marshall to complete our statement on the public comment.
All right, thank you very much, Mr. Vice Chair. This is Kelly Marshall for the record. So in compliance with newly updated NRS related to open meeting law, we just want people to know that if you're dialing in from a telephone in the United States, you can dial 1-253-205-0468. And when prompted, you enter the webinar ID of 894-893-75298. And the meeting passcode is 765594. When prompted, you can press *9 on your telephone to unmute you and indicate that you would like to make public comment. You can also raise your hand, or you can simply unmute yourself, and we will monitor all 3. So with that, Mr. Vice Chair, I'll turn it back to you to open public comment.
Thank you, Kelly. So I will turn it now to Dr. Dixon, our first comment.
Okay, thank you all. This is Dr. Dixon for the record. This is some information that I'm not sure would fit into the rest of the agenda today, so I thought I'd make it a public comment. I got a letter yesterday from West Care. I know most of you all are from the north, but you probably know about West Care. I hope that you know about West Care. It's a very important agency for us because they're the ones that'll take the patients that show up in the emergency room needing a detox and to start treatment. And due to, it's not clear in the letter, but I heard from another source that they're just not making enough money from their Medicaid billing. So they're going to close down the CTC, the Crisis Treatment Center, for the time being and reprogram whatever it is they're doing. Well, this is, and I guess it's August 15th, I think I saw was on the date. And so this is not good news for us, because it's the only place that really takes the uninsured patients. They work very hard to get them insured once they show up there too. So they get a lot of them put on Medicaid. So I think this is going to hurt tremendously. When we're thinking about treatment, we need to think about the fact that it costs money and someone's got to pay for it. And a lot of our patients, due to their circumstances, cannot pay for it. So losing a setup for that meets those is really sad. The other thing is that there was a clinic down here called the Huntridge Clinic, and it was set up to meet the needs of people with substance abuse, but also people with from the gay community and all those other initials. And it's a clinic run by a nurse practitioner, and so they provide relatively free to or Medicaid billable care. And for us at my clinic, they would come around and do hepatitis testing and HIV testing. They shut down for a while. They had grant problems, and they have reopened, but with half the staff, and I suppose that means half the services. And then finally, I got another notice today that Medicare is planning to cut its reimbursement to physicians. I think in the end, the number is going to be something between 1% and 2% of what they've been paying us, but they do that all the time. And so I think when we're thinking about all the things we want to do, we need to think about if there's no treatment available because people have shut down, that's not good for what our goals are. So that's all.
Thank you, Dr. Dixon. Kelly, I'll turn it back to you to monitor and see if we have any other public comments.
So if anyone would like to make public comment, please unmute yourself or raise your hand. M.O. Strom, you are currently unmuted. Would you like to make public comment? Oh, and M.O. Strom is gone. Okay. I do not see any other hands raised or folks unmuted, and I do not see anyone who has pressed *9. So I think that concludes our first set of public comment.
Thank you, Kelly. Steve Shell for the record. So we will now move on to agenda item number 3, review and approval of minutes from our June 27th Treatment and Recovery Subcommittee meeting. Since we do not have a quorum today, we will have to defer that item to a subsequent meeting. So moving on to agenda item number 4, we have a presentation on treatment and recovery for veterans by Abigail Began. She is with the VA Sierra Nevada Healthcare System. We're very glad to have her with us today. They are doing some great work in Northern Nevada. So I will now turn it over to Abigail. Hello, Abigail.
Hi, thank you for having me. I am very excited to share some of the information about the treatment options for veterans here at the Sierra Nevada VA Medical Center, as well as hopefully offer some relevant information that might be used for future action in the state of Nevada to help individuals diagnosed with substance use disorders. I think I have to let you know when to go to the next slide, so you can skip through disclosures. I don't have any affiliations or conflicts of interest with regards to this presentation. And so I'm going to start with just a very brief overview of the SUD services here at this VA. We do follow the ASAM levels of care, and that's the American Society of Addiction Medicine, which provides a really extensive definition of each level of care, and that's very helpful for ensuring continuity of care. We know that when individuals are referred to the appropriate level of care to start with and then receive the next level and what we call door-to-door treatment, that we have better outcomes. And so we do follow the defined ASAM levels of care. And just, I'm going to provide a brief overview for those of you who may not be as familiar with this, but level 4 is the medically managed detoxification services, which we provide within our VA. And we also have some community partnerships where we're able to send veterans if for some reason we're at capacity. And so that's that highest level of care. Again, that's a medically managed component, so 24/7 hospital services. And then the level below that is level 3. And essentially all level 3 services have a residential component. And so that's going to have a piece where the veteran or the individual who's in that level of care is actually living on site and receiving clinical interventions. Level 2, in Reno, Nevada, our VA, we do not have a residential program attached directly to our VA, but we utilize a partnership with the Las Vegas VA. And that's just a reflection of the way that the VAs are structured, where we have VISN resources. And while you may not have a residential facility on site, we collaborate and arrange travel so that veterans can access the VISN residential program. And for some reason we're at capacity at the Las Vegas residential rehabilitation program, then we utilize community partnerships and have veterans receive services within the community. Level 2 is the higher intensity clinical services, but on an outpatient level. And this is where we see most of our need. A lot of our veterans that we serve are able to be, their clinical needs are able to be met at the partial hospitalization level of care. And that essentially is exactly what it sounds like. It's a partial hospitalization program. So veterans are in structured clinical programming Monday through Friday. We do also offer Saturday services at this VA. And so veterans are in that structured program, and then we work with them to identify or help connect them to safe, supportive environments, housing environments if they don't have that. And then the level below that, which is still within this level 2, that high intensity outpatient services, is intensive outpatient programming. Most people are familiar with an IOP. That's common language in the field of addictions treatment. And the level below that is that basic, what we consider low clinical intensity outpatient services. And so that's for individuals who are a little bit further along in their recovery journey. And the step below that is 0.5 in ASAM language. And that's really considered early intervention and for individuals who don't meet diagnostic criteria for a substance use disorder. So at the VA in Reno, we cover that full spectrum. It is helpful, as I previously mentioned, to utilize ASAM and the ASAM definition of levels of care because it ensures that veterans are receiving the wraparound services that's defined in each of those levels, and as well as the continuity of care. With ASAM, and kind of the next bullet point, and what I really want to focus on with regards to what we have done at this VA and in other VAs that I have worked in and programs I've created, is we have really focused on ensuring we complete a comprehensive assessment, especially with the veteran population, where we're identifying co-occurring disorders and we're providing concurrent treatment. So as we're helping an individual around their sobriety goals and abstinence from substances, it's not uncommon that we see an exacerbation of other symptoms. And what we want to do is ensure that we're providing concurrent treatment to address those, which is essentially going to provide better outcomes. And so we do utilize the ASAM criteria. So ASAM defines levels of care, and it does a really great job of looking at 6 key dimensions in recovery. And these have been incorporated in our assessment process, as well as the language that we use to make the clinical recommendations. And those 6 dimensions, the first one's really looking at the complexity or the potential for withdrawal, and whether or not the individual is going to need a medically managed period where they're able to be supported. This is typically early on for a period of 1 to 4 weeks. And that is the first piece. And then the second dimension that we look at is any comorbidities. So any kind of medical condition or complication that's going to challenge their ability to participate in treatment or the potential for success in treatment. The next dimension that we look at is co-occurring. I've already touched on that. We really closely monitor other mental health symptoms. And this is something that we do with what we call measurement-based care. So from the start, when a veteran comes into services, we are monitoring symptoms, and we do focus pretty heavily on trauma. Given that we're the VA, we focus on trauma, anxiety, and depression. It's not uncommon, again, to see an increase in some of those symptoms, and so that helps to guide the individual's treatment plan. The next dimension that we look at is motivation. So we can have somebody who's reading high in these other dimensions, but if their motivation to engage is low and you put them in this high intensity program, it doesn't quite fit where they're at, and their potential for disengaging is much higher. So we do look at motivation, and ASAM identifies motivation as being a key determinant in placement. And the last two dimensions are withdrawal, or I apologize, relapse potential. So do they have any relapse prevention skills? Do they have insight into their cycle of relapse? And these are all conversations that we're having during this assessment process. And then the last dimension is environment. So we know that if an individual is in an environment that's conducive to their using, if they're in an environment that's not safe, homelessness, insecurities with basic needs, that the potential for continued use is much higher. And so we use those ASAM dimensions in addition to some additional assessment components that we use to complete that comprehensive biopsychosocial assessment and be able to make clinically appropriate recommendations. One of the challenges that we've identified in the VA as I've developed addictions programs for this VA and other VAs is that when you place veterans in programs that don't meet their clinical needs, so if you put a person in a higher level of clinical programming than what they need, they have just as much of a potential as an individual who's in too low of a level of disengaging in services or having relapse. So we really focus on comprehensive assessment and making sure that we're placing people in their clinically appropriate levels of care. The next area I want to touch on is the component of connection, belonging, and purpose. And this has been something that in the Reno VA we have really focused on, and we have broadened the way that we approach addictions treatment. We use a lot of evidence-based practices, and I can talk about cognitive behavioral therapy and motivational enhancement therapy and all of the recognized modalities that are used. And we do those things and they are helpful. However, we've also really brought in the emphasis on helping individuals in recovery make connections and make healthy connections. We know from studies that if an individual remains in the environment that they were in when they were using, that they are more likely to have a relapse. And so a lot of what we do is developing life skills. We have partnered with a lot of community resources to help give veterans opportunities to make connections. And I'll just provide a couple of those examples. In Reno, we've been very fortunate to partner with a nonprofit CrossFit gym called Upstate Nevada, and they offer free programming for veterans in recovery. And we've had great success with veterans getting connected there, finding community, finding a sense of belonging and purpose, and utilizing this while they're actively in programs with the VA, but then also when they're out of our programs. This is something that we see veterans continue with. Some of our other community partnerships have promoted opportunities for veterans to engage in service work. So we've partnered with the food banks and Humane Society. We've partnered with urban gardens to incorporate some horticulture. Some of the other opportunities that we offer to veterans that touch on connection, belonging, and purpose is rediscovering interests and hobbies and recreation. And so we have partnerships with the Art Museum and a couple of the other nonprofits in our area. And those are the pieces of recovery, those dimensions of recovery, where we don't always touch on in the formal EBPs that we use, but where we've broadened the services that we offer veterans. That's where we start to see some of these components be addressed. Another program that I just want to briefly mention that we have developed in the VA in the past 2 years is a program called Sierra Nevada Tracks. And this is a nature-based therapy program that utilizes acceptance and commitment therapy in combination with nature-based therapy, as well as what we call wellness exposure activities. And again, this touches on the connection, belonging, and purpose. So it gives veterans opportunities to connect with other veterans, to develop a community, to develop meaningful relationships, and to also contribute in a way where they feel that sense of purpose. They have a sense of worth. And of course, this helps to promote long-term recovery and is very in line with the goals of abstinence, but then also it improves overall mental health. You can flip to the next slide. It asked for this, so I know it's kind of implied. I'm with the VA said that multiple times. So yes, this is specific to veterans, but the information that I'm sharing, it can really be applied to anybody. I do want to briefly mention that I use the definition that the VA uses for veteran, and I intentionally utilize that for this presentation because not all veterans qualify for VA services. And so that's an area where if a veteran doesn't qualify for VA services, they're seeking services in the community and they're looking for access elsewhere. And that I think sometimes is a gap that we run into because veterans get directed to the VA because they're a veteran, but then if they don't qualify for VA services, they're not able to access treatment. We can flip to the next slide. Yes, so gaps. One of the gaps that we see in the VA is access to transitional living. And we, as a VA, we have a lot of partnerships and there's a lot of veteran-centric programming. So I feel very fortunate that we do have resources, and even with resources, we still see some challenges in accessing transitional living. Transitional living or sober housing or supportive housing, it's called a lot of different things, is a critical piece for this population because for individuals who have been actively using drugs and alcohol and have been in the addiction or relapse cycle, oftentimes they don't have supportive relationships. They don't have some of the life skills to navigate employment and managing finances and some of those basic pieces. They may not just have resources for safe, supportive housing. And so it's very challenging to serve veterans or individuals at any level lower than residential. Whereas what we see when we have access to transitional living, a lot of our population is able to receive services at a partial hospitalization or an intensive outpatient level of care, which from a cost perspective is much more cost efficient. And so we really try to connect veterans with some of these supportive housing options that we have. But again, there's barriers just with regards to availability, cost, and then eligibility. A lot of the partnerships we have in the VA are connected with our homeless program. So if a veteran's not homeless, it's very challenging to help them find transitional living. And then we oftentimes see, again, goes back to increase in disengaging in services or relapse potential because they're really not being served at the level that would best meet their clinical needs. Next slide. So recommendations. The most significant factors that we have seen impact the outcomes that we like to see in the VA is utilizing ASAM, having that common language, reducing the discrepancy around clinical recommendations by using that, and then touched on promoting continuity of care with using transitional living or supportive housing. And then finding ways and partnerships to help connect people with recovery or a supportive community. I think that concludes my last slide. I think we're opening up to questions.
Yes, thank you so much for that great presentation, Abigail. So do we have any committee members that have any questions or comments? I have a couple of I see Assemblywoman Thomas.
Yes, sir. Thank you so much for the presentation and that information, which I can use. I do appreciate as a retired United States Air Force vet. My question actually with the services that are out there, I'm looking at the whole person when they do come into recovery, because most of the time they, from what I've understood, a lot of veterans are homeless, and they lack health care, dental, eye exams, those type of things. So I was just wondering if there is a wraparound services that is being offered besides their addiction, because we know that that is the primary cause, but I want to make sure that that all barriers are met with our vets.
Yeah, of course, that's a great question and comment with regards to the importance of having that wraparound service. So two things, thank you for your service. And then not to self-promote VA, but I will say VA has done an incredible job at addressing homelessness among the veteran population. And that's a reflection of, I want to say 10 years ago, the Secretary of the Department of Veterans Affairs made that essentially the agenda and the platform is that we should not have homeless veterans. And so not just at this VA, but at all of the VAs I've worked at, there's really robust services for veterans who are not just homeless, but who are at risk for homelessness. And those programs, so we work closely with those programs. And then we also have addiction specialists embedded in all of our homeless programs. And they do offer case management. And, one of the most well-known VA programs is what's called HUD-VASH. And that's a partnership with the Housing and Urban Development and the VA. And what that does is it partners, they receive the voucher from HUD, and then they also receive an assigned case manager from the VA. And what we see is longer term outcomes with housing, with veterans remaining housed when they receive that case management component. And so, yes, veterans who are homeless and at risk for homelessness do receive those wraparound services through our homeless program. And then if they're in one program in the VA, it doesn't mean they can't receive services elsewhere. So a lot of times we do have veterans, even though they have access to an addiction specialist within homeless program services, they also come into our addiction programs, and they may also come into our what's called our PTSD clinical program, and they may also come into our general mental health program. So that's one of the nice things about the VA, and it's also one of the things that ties back into concurrent treatment, where our model is not, you have to be sober to work on this other thing. We can work on it as a team and work on it in line with the veterans' treatment goals. The VA has, in the past 2 years, really started focusing on the number of veterans who are diagnosed with a substance use disorder or meet criteria for a substance use disorder who never come into an addiction specialty clinic. And there's lots of reasons for that. There's stigma related to it. There's, a lot of barriers that can result in somebody not coming into an addictions program. So while we do have that in the VA, we have really been focusing on expanding access to addictions experts or specialists or providers within other departments. And that's kind of what I'm touching on there in the homeless program. But we also see that in our primary care setting, where we have addiction therapists embedded in there. We have them embedded in our trauma clinics, as well as other places in our facility.
Great. All right, thank you. And I would assume also those services would include the mental health aspect of it.
Correct.
Okay, great. Thank you so much.
Of course.
Steve Shell, for the record, I have a question, Abigail. I wanted to ask how you and the VA are incorporating peers into your model. There's a big push, regarding peer support specialists. And I'm just curious, what is the VA doing around the subject of peers?
Yeah, so we have a lot of peer support specialists, and we have peer support specialists that work within our addictions clinic, and similar to the model I was just referencing, where we have, it's what we call stepped care. So it just essentially means we have these specialties embedded in other clinics. So you can find peer supports in all of our different specialty clinics. And then we have several peer-led groups or modalities that are used. So WRAP, which is Wellness Recovery Action Plan, where veterans can attend a group where they can receive those services on an individual basis with a peer support specialist. We have a program called Veteran X, and we have our Seeking Safety, which is another modality that's often used with veterans who are diagnosed with trauma, both PTSD and SUD. And so we have veterans have access to those peer-led groups as well as individual. We have a lot of peers that do outreach. So, for example, some of our populations that we find to be the hardest to engage are veterans who are identified in a primary care setting, who appear to meet criteria for a substance use disorder. Some of the medical components, the provider or the physician is identifying as their alcohol or substance use is resulting in some of their symptoms, and so they're trying to refer them. And those are the veterans that we do not see coming in, and so that's the population that we have embedded addiction specialists as well as peer support specialists. We actually just got our peer support specialist that's attached to our primary care clinic on board, and the reason for that is these are veterans who really require more outreach. They require more personalized contact from the start. Whereas what we have found is if we have an administrative personnel call just to schedule an appointment, and our process is they call and they say, hey, we want to schedule you in this clinic. Those are the veterans that we tend to see not schedule. Whereas when we have a peer support reach out to them and they have that personalized contact and they have that context that this is another veteran and this is another veteran who has worked on their substance use goals, I'm going to talk to them about that. And so once we establish that, ties back to connection, that relationship, they're more likely to engage in services. And so peer supports are a critical provider in our addictions clinics as well as our other specialty clinics.
Very glad to hear all that, Abigail. Thank you.
Yeah.
Do we have any other questions or comments from our committee? Okay, hearing none, Abigail, we want to thank you again for taking time out of your day to come present to us. Thank you for the great work you're doing for our veterans. So we really appreciate it. So thank you again.
Of course, thank you very much for having me.
Thank you. So moving on to agenda item number 5, we will now have a presentation on pain management by Dr. Narizi, and I would like to thank him for also taking time out of his busy day seeing patients to be here to present to us. So I will now turn it over to Dr. Narizi. Hello.
Hi, this is Ali Narizi. I'm a pain specialist and anesthesiologist. And thanks, Steve. Thanks for having me back here to present again to committee, something that I'm truly passionate about in terms of the pain management. But what mostly important for our subject is how we address the acute pain and how we use alternative options that we have to address the painful injuries to prevent the patients to get on opioid. And I'll discuss later why it's important for us to prevent that from happening. And that's the best way that we have the prevention of the addiction in the patient. Next slide for me, please. So disclosure, I founded United Pain Urgent Care as the first pain urgent care in the country to address the type of treatment without use of opioid, or in some situation just minimize the use of the opioid and find the gap in our healthcare system, what the problem is and how we can address, and hopefully how we can have this type of projects in a different area of what we do. So as we know, there are different ways of managing the pain. So that's what we're going just to talk about, and hopefully we're able to solve some of the issues by changing the way the pain is being treated in this country when the acute injury happens. Next slide for me, please. Just introduction part of what is important. What we knew that currently, if the injury happens, our access to services does not exist in our healthcare system outside the emergency rooms. But even emergency rooms are able to do some limited in terms of injuries if they are not life-threatening or life-threatening conditions. And but also what it's important for us is we need to prevent that patients from being exposed to that initial phase of the opioid itself, because that initial phase, what I've seen that some of the studies that I go over, it becomes a reason for the patient, some of the patients that become addicted to opioids. There's sometimes a simple example analogy that we have for patients that say, when you take opioids, because of the neuroplasticity of the brain is so strong, and you have seen that in addiction, that the relapse is so strong, the reward pathway is so strong, that some of the changes is just not reversible. So I tell them, when you start taking opioid, think of you're turning into a pickle. If you're a pickle, you never turn back to cucumber. You're always a pickle. So how important it is when you take the opioid and some of this neuroplasticity changes in the brain pathway is strong that is not reversible. So, and we talked about some of the especially in opioid naive patients that we were talking about, they've never been exposed, but they're susceptible to become addicted to opioid. Why you want to expose these individuals to the opioid. And then talking about the early access in the treatment. So we know that every time we intervene as any aspect for the training, education, addiction, injuries, early intervention and access to the treatment is a key. The more we just stand by, not to do anything, we've seen the outcome and the results is not going to be favorable. Please, next slide. And let's look at the issues. One, the emergency rooms, what we deal is, so when you go to emergency rooms, typically the treatments can happen right away. They don't need any prior authorization requirement. However, if you want to take that to more of the urgent care setting, that you want to try just to kind of offer treatments, so some of these interventions, they require prior authorization. It means that you have to get the access to the health, to the payer, the insurance companies, and get their permission to provide. And guess this is not a process with just a phone call. And it's just the process takes days and days even to respond, and then denial. That we have seen it all the time for the patient care. So this is one of the big issues that we face when we offer this type of treatment in urgent care setting. Also another big issue is the capacity that we are facing with in terms of using the emergency rooms. As what we have seen during COVID, our system, the infrastructure is not designed for just massive number of patients going to emergency rooms. We don't have that capacity. So emergency rooms right now, typically when they triage the patient, they look at who is life-threatening, who is having a heart attack, who is having a stroke, maybe just having a problem with diabetes that is just low, high, they need to address. When it comes to the injury, painful, because they look at, okay, you're not dying, sit a few hours here. Maybe the plan is also get these patients as soon as possible out. Maybe just like give them some opioid medication, just open up my space because I'm waiting, expecting just to treat these life-threatening conditions. So it may not become also a right place to treat the patients. Next slide, please. So this is the big one that I want everyone just to pay attention because the studies have shown. And there is a huge, strongest predictor of misuse is the total duration of the opioid you are prescribing, and also the total and the length and the strength. But each prescription that we filled out was given associated with 44% increase in the rate of misuse. And each week that you refill that prescription, the misuse goes by 20%. Think of that situation that many of us have even seen with our family, friends. It's just significant back pain. Just give you a simple back pain, can't even move. It's just extreme pain. Go to emergency room, sit for a few hours. And by the way, these patients, they have taken, it's not something, oh, why don't you take other over-the-counter medication, ibuprofen? They have done that. If they come to ER, they've exhausted whatever they've had at hand to treat themselves. So the pain is significant. They're in significant agony. They can't move. So they wait a few hours, the treatments, and maybe just in ER, they don't even have that part of the training or people to do it. So maybe again, get the imaging, what emergency needs to be done, get some medication, and end up majority of them like given the opioid, and then kind of go and see your primary care here a few days. And guess that refill is going to get, there's no way they can see any specialty within a few weeks. Call the primary care, okay, I can't do anything. Let me just at least refill your pain medication opioid. And guess that's what we do. The most predictor becomes week and week and week of prescribing opioid. And then it gets to the specialty. In some situations, as we see, it's too late. You're not able to take them off. And then addiction, the rest of the problem comes after. So what I propose that I just call it, I call that ERA. It is a key component for us. So when you look at the component of the risk management of what we do, we have the hazard, we have vulnerability, and we have a capacity. So that comes into capacity building. So like say education, regulation, and access to alternative option. So we've done part of the education. I think we have not done enough education as like patients who are diabetic. I think we need to do more with it because people, they know way more about the diabetes, the complications, but they may not know much about the opioid. But we've done also great work. We've done some regulations, for example, at the state level with AB 474, just to kind of regulate that. But most importantly is just to get access. Just give me a simple example. If you think that the fatty food and greasy food is not good for people, so you say, okay, I'm educating you, you need to have a healthy diet, but also I'm regulating. I'm going to take any fat food away from you, but you cannot let them stay hungry. You have to give them healthy food. What's the option we have? Basically, we don't have option. How do you expect the ER things to treat these guys that are in significant pain, 10 out of 10 can't move? Because if the non-opioid medication would have helped, they would have done it in the first place. So then, okay, let's just use some of the alternative options that we have, the treatments, things that I would go over. Injections, they're not able to offer it because they don't have anywhere. Nowhere outside can anyone else do it. An urgent care, normal one, they don't do. And then guess, takes a few weeks to get the specialty. So we see that we're missing the most important part of our part. Where's the access? You've seen a lot of access to the right treatment at the time of the injury that's missing. So I think that's one of the parts that I think the state and any federal level, just as important for people to know, to provide that kind of care. And it's not all about the education and regulation only. Next slide, please. So who are the special populations that we will look at? Look at just everyone. It's just from the athletes, especially the youth and adults, a lot of the sport injuries. They come here in significant pain, then you just do and put them on opioids, and that's the worst thing because the pain is significant. Yeah, you're human. How can I just sit a patient that cries in pain and agony? I walk out and said, you know what? Sorry, I don't have any options here, and the opioid is regulated. I'm not going, and goodbye. You suffer from pain, and just no way. So the hospital people, they want to get these patients under control, but when the option is limited to what they've left with, that's what we're facing. Then the opioid abuse and problems after. So veterans, cancer patient, palliative care, workers' comp patients, and the senior. So it's just, or people in recovery. You know, you don't want to expose them again to opioid, but they can break bone. They can just injure themselves. And these people who have done so well in programs not to have any relapse, you don't want just to expose them to the opioid, and that's another option to treat these patients with. Next slide for me, please. And some of the parts will be, at least we know that when it comes to Medicare and Medicaid programs, we don't need that list of prior authorization. So it's just medical necessity. We can proceed with these treatments in urgent care setting when they come to us to start the treatments. And but we wanted just to show that that's a right way to do. While a lot of the payers, beside the care, the cost is important for us as well. We know everything we know how we can make it cost effective. So thanks to some of the Prominence Health and payers, we did the cost analysis studies that we compare these patients to going to emergency rooms versus going to our urgent care model for the same problem. For example, back pain, rib fracture. And then the treatments that we've even it's not been offered, but also we save these payers 546%. It's a huge number compared, because they ran that and the analysis and they saw the cost associated with our care and that one. So that comes down to Medicare and Medicaid programs. So they can have that sort of saving for these type of injuries that they have for the patients. What also we have seen success, if you're familiar with our area, renowned hospitals, they've become a source that they from emergency rooms, they refer these patients directly to our urgent care because they know exactly they're not able to treat them, and they just end up giving opioid. So these patients have gone to our facility to give the treatments right away, which is some of the interventional treatments. Next slide, please. So let's talk about give you some examples, for example, and what the treatments are. So you have rib fractures, for example, from mountain biking. Those are very common. It is one of the painful situations that the ribs fractures, pain to the point that you cannot even breathe well. If you don't breathe well, you don't have to wash out your lungs so well. And over time, you can even get pneumonia because you're not able to do. So typically in hospitals, the treatment is they get you in, they give you some pain medication, opioid, or they admit you overnight just to try to get the pain under control so you can breathe that. But it's a simple fact. You can just block the nerve that is fractured right on there. And for long term, for 24 hours, or sometimes can repeat that easily. So then there's no pain associated with it, minimized. So they don't need opioid. A very simple fact, but it's not being utilized because there's no access to it. That's what we offer in urgent care. So they send a patient for rib fracture, treat that here. Or you have a fracture that you've seen that in hospitals before the surgery, they do the nerve block on your leg parts because they don't need to use opioid anesthesia for. But guess after part, even there's no fracture, no need surgery, no access to provide that kind of nerve block for the patient who injured. So that's what we're offering, or epidural injections, or for migraine headaches. A lot of them is just in a significant pain, and we just do occipital, we do supraorbital block, occipital, things that will break that cycle for the patient in urgent care setting that is not being done because there's no training, no access to it. Next slide for me, please. So these are the gaps that we will look at into the current system. Is first, when the pain and injury happens in our setting, they don't offer that treatment. The cost is higher and is not life-threatening conditions for these patients, some of them. And so the patient's still wandering around. We've had patients that they go multiple times to ER, the pain is significant, can't do anything, see your primary care, so as we discussed, will take some time and then end up being on opioid. And then one of the parts that the gap is education. We're still working on education. What the gaps that our messaging is just very hard. People that don't know, you think everything there's a little magic pills. You want to lose weight. Where's my pill? Just to lose weight with it, instead of just changing the lifestyle things. With pain, same thing. Either you think that there's a surgery or there's a pill for it, but there's lack of information that what happens way before that. Some of these treatments can be done easily, right, for you safely to decrease the use of narcotic opioid. And I think the third gap is the expansion. So this idea we have studied for 2 years as a kind of pilot run, we think that needs just to expand, but also we have to make sure that payers understand, and then to take some of these prior authorization away. Some of the insurance companies have done it for us because they have seen the results, but I'm hoping to see more of the bigger insurance companies to be on board. Not just to say, hey, we'll support the opioid, but at the end, when you get to the point, they just not support anything and continue what has been done all, because the change is not easy. Everyone's comfortable with even the change, what's not right, but still comfortable because they're afraid of the change. And that's what we're hoping to see in the state to change as well. Next slide for me, please. Okay, so recommendation, and one is just, I think, as we talked about it, provide the early access to these patients when the injury happens or they have painful pathologies, and just to think that instead of being the opioid or sitting in emergency rooms, just to go to these type of facilities to benefit from. And then sometimes we need, maybe in a legislation way, just to waive some of those authorizations. And I don't know if you've seen the authorization. It's just sometimes it's just you laugh, and then ask them, it's just pain significant, the back can't move. Has the patient tried 6 weeks of physical therapy? Physical therapy, understand, but when his pain is 10 out of 10 can move, how do you want to even just get 6 weeks of physical therapy? It's just the old things that even just does not even pertain to what we deal with. And guess they just go on narcotics and opioids to bring the pain down. And they're hoping, but the reason they're hoping is just hoping patients not seeking care, and how somehow over time gets better. They don't have to handle that. And everything has the place, the physical therapy is strengthening, it is right. But the timing for this acute painful injury, that's not the right way to address the issue. and then to basically, as I said, just the strategies of initiative just to make sure that we can expand this type of facilities in the state. Those are, I think, the recommendations that I do have. And this is my contact information. And I believe that concludes my discussion about the pain management in acute setting. And these are the studies that are referred to during my talk.
Steve Shell, for the record. Dr. Nunezi, thank you so much for all the great work you're doing. I wanted to open it up to my fellow subcommittee members for any questions or comments. I wanted to say, Dr. Nunezi, this is Steve Shell again for the record. I was very pleased to see the different populations that you listed that you've been focusing on, because those are outlined in AB 374. But I wanted to ask you about pregnant women and if you're doing any work in that area with pregnant women.
Yes, the pregnant, this is Ali Nerizi again. Yes, the pregnant woman, we have the treatments. So you have to understand that, for example, we use a lot of fluoroscopy, X-ray. In that situations, we use the ultrasound for some of the treatments we do, which is still safe because a lot of the local anesthetic and numbing that we use, they don't have much of systemic absorption to affect the fetus or the mom. So they can be pretty safe, especially like if you have a migraine attack, you can still do. And some of the parts we use the ultrasound for it just safely to perform some of these treatments.
Great. Any other questions or comments from our subcommittee members? Dr. Nunezi, thank you again so much for your innovation and for bringing attention to alternative treatments. We really appreciate the work you're doing. So thank you again for being here today.
Thanks again for having me. Appreciate that. Look forward to talking with all of you again. Thanks.
Thank you. So moving on to agenda item number 6, an overview of recommendations received and next steps. Due to not having a quorum today, we can certainly review the recommendations that have been made thus far, but we won't be able to take any action. So moving on to the next slide. So the SURG Treatment and Recovery Subcommittee met on March 21st and reviewed our areas of focus for SURG. We identified speakers and topics we would like presenters on. 2 presentations were provided on May 16th, as you will see noted. These were recorded and posted so that members and the public could review prior to the June 27th meeting. At the June 27th meeting, Chair Lisa Lee summarized the recommendations, and the Treatment and Recovery Subcommittee discussed the recommendations. So in this slide, you will see that the recommendations that have been received thus far, and we can just, I can just read through these quickly. The first recommendation was submitted by Chair Lisa Lee: prevention and overdose prevention outreach to underserved communities, including BIPOC communities. The justification is a recommendation from this subcommittee was to expand overdose prevention outreach to BIPOC communities. This recommendation is based on racial disproportionality in our state's overdose fatality data. And the presenter suggestion, which we've already heard from, was Donald Griffin and Romar Tolliver from Black Wall Street, Reno. And then the second recommendation was submitted by Vice Chair Steve Shell, a presentation from Nevada Department of Veterans Services. The justification again was the VA provides a variety of services around the state that are pertinent to our focus on special populations. And the presenter suggestion was Dr. Joseph Simpson from the Reno VA system, or his designee, Abigail Birgan, who we heard from today. So the recommendations from Donald Griffin's presentation, who is with Black Wall Street Reno, are as follows. Prioritize programming and funding specific to organizations reaching Indigenous African-American community members. Promote diversion and deflection programs for Indigenous African-American people and facilitate access to treatment. Engage Indigenous African-American people and organizations in campaigns, billboards, and messaging related to substance use. Support and implement Track B model with funding for staff and infrastructure to stand up newsstands and/or vending machines for Indigenous African Americans. And last, address the school to prison pipeline, and in parentheses, new Jim Crow laws through policy and legislation. And then we also heard from Sean O'Donnell with the Foundation for Recovery, and these are the recommendations from him. First, stand up peer recovery specialists independently of treatment with targeted funding. Let people who are directly impacted have resources to do work in communities. Think outside the box, working with those who have historically been left out, thus creating a more diverse workforce. And last, support peer recovery support specialist training events, including train the trainer programs with technical support for other trainers. So in the next slide, the only recommendation in front of the subcommittee currently is item 1, which is to support prevention and overdose prevention outreach to underserved communities, including BIPOC communities. Item number 2 was discussed at our June meeting, and the subcommittee agreed to workshop this to include all special populations defined by the SURG. The subcommittee discussed the opportunity for outreach to underserved communities, including LGBTQIA+ and BIPOC. They also discussed weaving in inclusion of innovative approaches to harm reduction by accessibility, such as vending machines and recycled newspaper boxes. We also talked about ways to broaden recommendations beyond specific programs.
Vice Chair Shell, would you like me to summarize that second bullet point?
Yes, please do, Kelly. I'm sorry, I was taking a note of something, but yes, I'll turn it over to you, Kelly. Thank you.
Excellent. Okay,
Thank
so also what was designed to be workshopped today, so this is more planting a seed, Kelly Marshall for the record, was the idea of enhancing peer support for underserved populations, specifically through increased reimbursement rates, train the trainer models, and policy changes to address limitations to the use of peers in some settings. Those were also linked back to Sean O'Donnell's presentation. And then the subcommittee discussed ensuring adequate funding for these priorities, targeting special populations, increasing reimbursement rates, and then offering standalone service provision opportunities for peers. And so that was something that we were going to discuss today. We were going to workshop both of those recommendations based on the direction from the subcommittee in June. And so I think one of the things, to turn it back over to you, Vice Chair Shell, and I don't know if you want to go through the rest of the recommendations first and then come to a discussion, but it really is, how do we get to a place where there are tangible recommendations in front of this subcommittee so that they can score them in advance of presenting them to the full SURG in October.
So Steve Shell for the record, Kelly. So if my fellow subcommittee members do not object, I'm thinking maybe we should go through all the recommendation first and then come back to a discussion on what we would like to see happen going forward. So if there isn't any objection. Okay, great. So in this slide, Dr. Narizi presented to the full SURG meeting for harm reduction back in April 2023. These recommendations then went to the prevention subcommittee, which was charged with developing prevention recommendations regarding harm reduction. The prevention subcommittee then forwarded this slate of recommendations on alternative pain treatment to our treatment and recovery subcommittee, as they felt it was better under our responsibility. And as Dr. Narizi shared in his presentation, we can just read through his recommendations here. But the first one is eliminate the need for prior authorization, either through legislation or persuade insurance carriers to sanction opioid alternative treatments. Item B, provide early access to patients who would otherwise be prescribed opioids if treated in an emergency room setting. Item C, expand this strategic initiative to other areas of the state who are faced with the same opioid addiction issues. Item D, he had recommended if you would like to combine any of these into one recommendation or add additional details, please do so. And then item E, additional comments to combine recommendations from the SURG members. I would include training on opioid stewardship, provider training on alternatives to opioids, patient educational materials on tapering, and options for pain management.
Mr. Vice Chair, Kelly Marshall for the record. I believe this as a package was delivered from the prevention subcommittee, so that bullet point under E is then an additional suggestion that goes beyond what Dr. Nairezi presented in April and then again today. And that was part of why we wanted him to present, was so this subcommittee could take up that recommendation. And so the prevention subcommittee is who stated that they would include training on opioid stewardship. So that's feedback from another SURG member on prevention subcommittee.
Great, thank you, Kelly. So moving on to Steve Shell again for the record, moving on to our 2022 recommendations, just to refresh everyone's memory. Hopefully everyone will remember these recommendations that we made that went into the last annual report for SURG, but let's just go through each of these. The first one was to expand access to MAT, medication-assisted treatment, and recovery support for SUD, limit barriers to individuals seeking treatment regardless of the ability to pay, and encourage the use of hub and spoke systems, as well as recovery support, including use and promotion of telehealth, considering the modifications that have been made under the emergency policies, and pursuing innovative programs such as establishing bridge MAP programs in emergency departments. The second recommendation there was to implement follow-ups and referrals and linkage of care for justice-involved individuals, including individuals leaving the justice system and pregnant or birthing persons with opioid use disorder. Our third recommendation was to facilitate opportunities for entry into treatment and or recovery, ensure that Black, Latinx, Hispanic, Indigenous, and people of color communities are receiving overdose prevention, recognition, and reversal training, and overdose prevention supplies such as fentanyl test strips and naloxone to reduce fatal overdoses among Black, Latinx, Hispanic, Indigenous individuals, and people of color in Nevada. The fourth recommendation was to significantly increase capacity, including access to treatment facilities and beds for intensive care coordination to facilitate transitions and to divert youth at risk of higher level of care and or system involvement, and implement a specialized child welfare service delivery model that improves outcomes for children and families affected by parental substance use and child maltreatment. The fifth recommendation was to implement changes to recruitment, retention, and compensation of health and behavioral healthcare workers, and enhance compensation in alignment with the Commission on Behavioral Health Board's letter to the governor of June 22nd. Additionally, continue to sustain and expand investment in community health workers, peer recovery specialists, and certified prevention specialists by implementing changes to recruitment, retention, and compensation. The sixth recommendation was to engage individuals with lived experience in programming design considerations. So that was quite a few recommendations. I think they each, are unique in their own way. But, at this point, I would like to open it up to my fellow subcommittee members for any discussion regarding the lengthy list of recommendations that I just went over, and get your thoughts on where you think they stand at the moment, particularly those from 2022. Any questions or comments? I see Dr. Dixon.
I guess the thing is, we're making recommendations, and I guess this was in our report for last year, right?
Yes.
What's the next? I mean, they're all good recommendations, But what's the next step and who's going to take it?
So Kelly, I defer that back to you because I know you're much more knowledgeable about this process for SURG.
Thank you, Mr. Vice Chair. So Kelly Marshall for the record. So I would just remind the subcommittee members that the first slate of recommendations really were presented in 2022 because this committee was only formed in 2021. So in our first annual report in January of 2022, which was the 2021 report, the recommendation was really about establishing these 3 subcommittees and how the SURG was going to operate. So now we have our first set of recommendations. What we did was pulled out the treatment and recovery recommendations so that you could review them. And in other subcommittees, some members have elevated the issue to say, we want an opportunity to be able to resubmit a recommendation. Like just because it was in the 2022 report, if it did not get, for example, legislative movement, or policy has not yet been changed, or a program has not yet been implemented. So for example, if we go back, we heard a presentation last year on a specialized child welfare service delivery model that improved outcomes for children and families affected by parental substance use and child maltreatment. This group pushed that recommendation forward. To my knowledge, there was no action legislatively and none that we are aware of programmatically. So then the question becomes, is there still a need to significantly increase capacity, including access to treatment facilities and implementing that specialized child welfare service delivery model? And if so, what does the subcommittee want to do? So there's really 2 pathways. One is that the subcommittee as a whole could say, you know what, we have not achieved our goals yet with these recommendations. We would like to bring them forward again. Or an individual subcommittee member could submit them in the survey that we send out to subcommittee members saying, what recommendations do you have? They could submit that recommendation again. They could reword it, combine it with something else, refine it in some way. But those are 2 options. The third option is that you say, well, we made the recommendation, we're good with just letting it lie and see if anybody does anything. So we were not in this position a year ago because we didn't have recommendations that we had made that we wanted to retrospectively examine. I think at the SURG meeting in July, there was a legislative overview that indicated that, you know, some of our recommendations had movement for them, but others did not, or it was not fully realized, the recommendation that was made. And so that's really the question for this subcommittee is how both do you want to handle the new recommendations that have come out of presentations such as Dr. Nairezi's or the veterans presentation, or the peer support or outreach to special populations, those recommendations, including the ones that you agreed you wanted to workshop, and then what do you do with those 2022 recommendations? So I think it's obviously, because this is not an official meeting, we can't have a motion, which is what I think Vice Chair Shell, that's what you were hoping for, is that we could get to a motion. But we can certainly have discussion about what the philosophy might be of this subcommittee in both dealing with those 2022 recommendations and then also refining 2023 recommendations in anticipation of going forward to the SURG in October. I hope that was helpful.
Well, partially. You know, when I think about what doctors do is we spend some time with our patient, get a lot of data, make a diagnosis and initiate a treatment plan. And we go very fast from diagnosis to treatment plan. I feel like we are not going from diagnosis to treatment plan. And, but in regards to what you were saying about the legislature, we're not going to do bills, but the interim committee, the Health and Human Services interim committee is the place to present recommendations, maybe even put in more specific terms, and hope that they will pick them up and design bills, because they're the ones with the bills. And there are others too, but they have most of the bills that are related to what we're talking about. And so it seems to me that's, we have one legislator with us, but it seems that we need to do that. We need to start turning these into legislative actions so that they actually happen. I'm not big on dealing with the budget because I never feel like we have a lot of input into the state budget, but at least we do into bills that might create some programs or something like that.
Kelly, Steve Shell for the record. To Dr. Dixon's point, I'm curious if we can drill down on each of these 2022 recommendations to see if there are any or parts of any of these recommendations that have already gone into legislation. I'm just curious. I know we had so many bills in this last session that I've not even been able, and I'm sure everybody can probably relate, but I'm not really sure if a lot of these recommendations were included in some of the bills that passed.
So Kelly Marshall for the record, Vice Chair Shell, I see that Laura Hill has taken herself off mute. Laura actually presented at the SURG meeting, has presented at previous subcommittee member meetings regarding the status of legislation. So I'm just interested, not to pass the buck here, Laura, but I wondered if you wanted to jump in.
Well, so we all know this legislation is very complex. So the summaries that we presented to the SURG kind of identify some elements of recommendations that were passed. In many cases, the full recommendation wasn't necessarily implemented. So I was just thinking that it probably would be helpful to subcommittee members to have some kind of analysis of what elements of those recommendations were addressed and what elements of those recommendations were not addressed. And it's kind of hard to do that in real time. I did pull up that summary sheet we had, but I think for the purposes of your discussion that it's maybe not as helpful as it could be. I don't know if the three of you who are present have some specific references regarding legislation that went through that you do want to discuss with other members to identify possible next steps, or if you want to wait and get something more from staff on that, and possibly Assemblywoman Thomas would have some specific elements that she might be familiar with. That, and I don't mean to put you on the spot either. I just am not sure who has what kind of information, because different people were following different bills.
Right, and Assemblywoman Claire Thomas, for the record, I was on committees that apparently did not get any of the SURG legislation. I believe that most of it came through the judiciary, and when presented to the full committees for votes, I think that was one of the only times that we actually saw some of the language. And my question was, as far as the judicial portion of the bills, when we elevated sentencing, I had great concern about that. So if we could get that, I believe that it went through. the AG's bill. I really do believe that went through.
Yes, it did. They changed the weight range for
Right.
what would be considered trafficking. So that was raised a bit.
And that was a concern that most of us had. You are correct. So that was the only one that I can, say that I had concern with. And when they did that, I believe we passed it.
Right.
Is Senator Donati on one of the on the SURG, and is he on one of the other subcommittees?
He's on
Kelly
prevention.
Marshall. Oh, go ahead, Laura.
Sorry. He had been chairing the prevention subcommittee, and now he would be a regular member of the prevention subcommittee.
Because he probably took more of a lead in the legislature on health and especially mental health kind of stuff than just about anybody else. And so it might be worth having him present to us on what he thinks would be some good bills to, because he's going to apparently he's going to head the interim health committee. And so maybe talking with him, if we want to choose some things that we think are important, to discuss how to go about working them into something.
Mr. Vice Chair, I see that Terry Kearns, who is also part of a subcommittee, has raised her hand.
Thank you, Kelly. I'll turn it over to Terry Kearns. Hello, Dr. Kearns.
Hi, I was just listening in on your meeting, Terry Kearns, staff for the Attorney General's office. And I just wanted to provide maybe a little bit of context to the conversation. Not everything that we made recommendations for had to do with legislation. So some things were to, ask for more funding through DHHS or, those sorts of things. I do know that a couple of the other recommendations, while they were recommendations from the SURG committee, were sponsored by others. And an example that I'll give you is one of our recommendations was to expand the behavioral health workforce. And I know that the regional behavioral health policy boards, that was their recommendation. So what we did is supported that recommendation moving forward. And I believe there was some legislation in terms of getting some of the community health workers covered under Medicaid. So that was one that moved forward. Another that was pushed forward from the SURG was to support having overdose fatality reviews. And that was a legislation that was pushed forward by someone else. I don't remember who, so I apologize to you for that. But that was moved forward. I think there were some modifications to that, and it ends up that in Clark County, they're going to pilot doing a type of an overdose fatality review. So a couple of the recommendations we made, but we didn't sponsor, I guess is the way I would say it, the legislation, but it was supported through other people who sponsored the legislation. Another component of what we've done with some of the recommendations is made those recommendations to the director of DHHS and the advisory committee for Resilient Nevada on how to use some of the funds for Resilient Nevada. So not everything will be legislation, but some will be just recommendations for, I guess, for lack of a better way, how to carve out the pie of where the funding goes. So I just wanted to add that context if that helps at all.
No, that was very helpful. Thank you.
And Vice Chair Kelly Marshall, for the record, just to piggyback on what Dr. Kearns said, we categorized recommendations in the report, I think, under categories such as policy. Is this a policy change? Is this a legislation or regulation change? Which can sometimes be a policy change, or was it a funding recommendation? In the justifications, but those didn't always rise to the top, but that was part of why we sent out the 2022 report so that people could see the context of the justification and what was being asked for.
So Kelly, regarding the analysis, is who would we technically lean on to be the point person providing that analysis to us? Would that be your team or?
So I think under the heading of Kelly Marshall, for the record, under the heading of no good deed goes unpunished, Laura Hale would be charged with at least following up on the recommendations from treatment and recovery. And, you know, Laura was the key author on the 2022 report. So she's intimately familiar. She also, you know, is a former state employee that has extensive work on the policy funding regulation arena. So I think we could ask Laura to just do follow up on those treatment and recovery recommendations to see if we could get some more clarity about what the status is of those recommendations as of today.
Yeah, that would be great, Laura. And, you know, back to Dr. Dixon's point, I think that would then help us, you know, either narrow our recommendations or expand, you know, before we make our final recommendations to the full SURG committee.
Yeah, I'll be happy to put that together and we'll get it sent out to members so that people can review that.
Great. Thank you, Laura.
You're welcome.
Is there any other discussion regarding the 2022 recommendations or those that have been brought forward this year? Any other thoughts, Kelly, regarding the recommendations? Anything we may have missed?
No, Kelly Marshall, for the record. I just wonder if maybe we do go on to that that next agenda item 8, skipping 7, so that we can review the timeline so that the subcommittee members have a good sense of like what we're managing towards.
Okay, very good, Kelly. Thank you. So Steve Shell, for the record, again, as Kelly stated, we'll skip over agenda item number 7 and move to number 8, recommendations for the scoring process and timing. These were discussed at the July SURG meeting. And so Kelly will now give us an overview.
All right, so Kelly Marshall, for the record, just to talk about the timeline for the SURG meetings and recommendations. We do have a September meeting scheduled for the subcommittee. Our job between now and that meeting is to refine recommendations based on feedback from the SURG. So in the case of the prevention subcommittee, they sent a recommendation to you. They're expecting you to make a decision about what you're going to do with that. Obviously, you cannot do that today because we do not have a quorum. Then we are working on refining a process based on the discussion that was had at the SURG meeting last week related to scoring and then weighting or ranking recommendations. So those tools will be coming. You may recall you saw those tools to do scoring. We need recommendations in order to do the scoring. So that really is what the onus is on this group moving forward, is getting to a place where we have recommendations, because in October, it will then be Chair Lee's responsibility to present those recommendations to the full SURG. And that's where that deliberation process then starts in earnest from October through December, because by December, we need to finalize those recommendations. This subcommittee may recall that we not only met in September, this subcommittee had to meet in October because the SURG in October sent some recommendations back to us and said, can you combine this one with this one? And so we had lengthy meetings to respond to the feedback from the SURG. So first we need a slate of recommendations to provide to the SURG, and then we need to be able to respond to the SURG by refining our recommendations. All of that managing towards the December SURG meeting, where the SURG as a whole will finalize the recommendations to be included in the annual report. And then that will be placed into an outline that you'll review for the annual report. And we'll also have a presentation of the DHHS annual report at that meeting. And then in January, you will be asked to approve the final annual report with all of the final recommendations in it. So I just wanted to note that July through September timeframe, which is listed as subcommittee meetings, is critical. And really the next step is for us to get those recommendations. So if a subcommittee member wanted to take this PowerPoint presentation, look at the recommendations and submit a recommendation, that would be one approach, as Vice Chair Shell noted. At this point, we only have one official recommendation, and that was for extending outreach to special populations, including BIPOC, LGBTQ, and other special populations that are addressed in AB 374. And then we have another 2 recommendations to workshop, and the prevention recommendation that was forwarded to the subcommittee. So I'm not a mind reader, but if I were, I would say, I think we're going to be meeting in August, which we don't have something scheduled right now, and September, because I am concerned that we might not be able to just finalize recommendations in September for presentation to the SURG in October. But I would defer to the direction, if we're not making decisions, but if the chair had direction to provide to us, or if subcommittee members wanted to weigh in about whether they think it's feasible to meet in August, that would be helpful. Otherwise, we could try for 2 meetings in September. But the meeting in October, Laura, I was going to ask you if you could just pop in with when the October meeting is. I think it's pretty early in the month.
Let me just take a look. Hang on.
Okay. And so I'm just worried that we won't have time in October to prepare recommendations prior to the October SURG meeting, but we may need to meet after that meeting in October to finalize recommendations based on the feedback we get. Sorry, that was a very lengthy response.
So October 11th is the full SURG meeting, if that's what you're asking, Kelly.
Yes.
Yeah.
It is. Thank you.
Chair Shell, could I just add another point?
Yes, Laura, please. Yes.
Thank you. So from the SURG meeting, you all agreed to use the new scoring matrix as part of your subcommittee meetings. And I think when you're looking at these recommendations between now and the next meeting, maybe take a look at that weighting tool and see how you might apply that. I can imagine when you get to the next meeting and having a quorum and new members who maybe weren't a part of this, just to be able to move the process along, to take a look at that matrix with these recommendations in mind, and how you might apply that, or if you have questions about that, so that we can try to get them addressed sooner rather than later.
So Kelly, Steve Shell for the record, at this point, will you be having that discussion with Chair Lee about scheduling a meeting for us possibly in August?
So Kelly Marshall for the record, unfortunately, Chair Lee is out on medical leave, so I don't believe that I would be able to. I think what SEI would do as staff support is just reach out to the subcommittee members and do a poll to see if we can schedule something in August. The other thing that we can do is we can take the slides with the recommendations and just send those out to the subcommittee along with the tool, the weighting tool, so that you would have a chance to review that in advance of the August meeting, assuming we can get one scheduled.
That would
With
be
the
helpful,
quorum.
Kelly. With the quorum, yes. Thank you. Do my fellow subcommittee members have any other questions or comments regarding the timeline or anything else regarding the recommendations at this point? it sounds like we still have a lot of work to do before we make that, before Chair Lee makes these recommendations to the SURG in October. So, but rest assured, Kelly, I'm sure we're all up for the task and can get this done. So Kelly, do we want to go back to agenda item number 7? Do we need to, or?
I don't think so. Actually we could, so let me do that for you. Go ahead.
So, well, I know regarding presentations, I know that we already have Marissa Brown with the Nevada Hospital Association scheduled for our September 19th meeting, and she will be discussing the bridge program, which I think is pertinent to what we've been discussing and hearing from some of our other presenters. We also have a list of some other possible presenters that we wanted to mention today to see if there's any interest from the group. The first one is Katro Henderson, who is a certified alcohol and drug counselor with the Adelson Clinic. The other is Kaylin C., who is with the Washington Heights Corner Project. And then Kat Wright is an administrative manager with Track B Exchange in Las Vegas.
And Kelly Marshall, for the record, I just wanted to note there's two interesting dynamics occurring right now. One is that we heard a summary from other subcommittees at the SURG meeting last week, and another subcommittee already received presentations on the bridge program. Dr. Dixon, you had also recommended Marissa Brown make a presentation on the bridge program. So she is confirmed for the September meeting. Kat Reich, the fourth bullet down, presented on harm reduction at the April full SURG meeting on harm reduction. So my question really for the subcommittee is, given that we've had considerable difficulties scheduling with Kaylin C., we've been trying to schedule with her for 1.5 years now, and she's just nationally recognized, and so getting her schedule to align with ours, she's on the East Coast, we're on the West Coast, has been challenging. And then Katro Henderson has expressed interest, but I think the question I would ask is, does the subcommittee beyond Marissa Brown on September 19th, who is confirmed, want additional presentations, or do you want to focus on recommendations?
This is Steve Shell for the record. I'll just say that I personally would like to see us just focus on the recommendations. I think we could certainly continue with Marissa's presentation, but outside of that, I don't have any interest in any others unless my fellow committee members do. Oh, Dr. Dixon.
Do we know what we were wanting someone from the Adelson Clinic to talk about?
Specifically treatment options for youth. It was one of the special populations. Kelly Marshall, for the record. So that was recommended that the Adelson Clinic had a youth specific program, and we were going to hear about that special population and recommendations for that, similar to what we heard today for veterans. So it's part of those subpopulations that are required to be addressed as part of EB 374.
Well, there was an interesting article appeared. Where did it appear? JAMA, New England Journal, something, and then it was put into the regular news about the fact that there's nowhere to send teenagers for medication-assisted treatment, or very few. There's very little options, and although I guess a lot of us, as parents, don't like the thought that our kids might need this, they obviously do, and so it's always been kind of more the thought of the treatment community that you stick to the non-medication treatments for kids, teenagers. And but I think Dr. Adelson got grants in the past. I assume she still has them. I don't know, to at least use methadone with with some teens, and I don't know what age is the limit. But I talked to my clinic, and we will take teens from 16 and 17 and 18, as long as the parents will come and approve, consent, whatever. So I'm kind of interested in where we really are with teens and what the Adelson Clinic has been able to do, because I mean, this problem is this is down into middle school at least of a problem, and we need to figure out some way to get these kids going in a better direction. And
Now that Claire Thomas, Assemblywoman, for the record, I would agree wholeheartedly with Dr. Dixon now that I understand what the Edelson Clinic would be presenting to us. That would be something that I would really, really be interested in.
Steve Shell, for the record, yes, I agree with Assemblywoman Thomas. Had I known that this was about youth, I would have also been saying, yes, we definitely need that one. So I'm now interested in that, Kelly, knowing that it is specific, about youth. So
Kelly Marshall, for the record. So we have been reaching out. I think if we can get an August meeting scheduled, then we can reach out to see if Katro Henderson is available. And also just a reminder to the subcommittee members that you have multiple emails from me with a survey link. You can recommend presenters. So if there's somebody else within the state that you would want to present on youth treatment options and recommendations, because what we're really interested in is the recommendations that they bring of, evidence-based programs that could be expanded, or practices that could be expanded. So we will continue our outreach efforts in that regard with a priority on youth.
great. So jumping ahead to agenda item number 9, public comment. Kelly, I'll read bullet 1 and then you can read bullet 2. So public comment will be received via Zoom by raising your hand or unmuting yourself when asked for public comment. Public comment shall be limited to 3 minutes per person. This is a period devoted to comments by the general public, if any, and discussion of those comments. No action may be taken upon a matter raised during a period devoted to comments by the general public until the matter itself has been specifically included on an agenda as an item upon which action may be taken pursuant to NRS 241.020.
And Kelly Marshall, for the record, just a reminder, if you're dialing in from a telephone in the US, dial 1-253-205-0468. When you're prompted, our webinar ID is 894-8937-5298. And then the meeting passcode is 765594. And so if anyone has dialed in by phone, you can press *9. So we can ask you to unmute. You can also raise your hand, or you can take yourself off mute and we'll call on you. So is there any public comment? I don't see anything in the chat, Vice Chair Shell.
Okay, thank you, Kelly.
And I don't see anybody unmuted other than Dr. Dixon. I believe she is unmuted from her previous comment, not to make public comment.
If we don't have any further discussion, we can move on to agenda item number 10, which is adjournment. We'll wish Chair Lee a speedy recovery during her medical leave, and we will look forward to having a quorum at our next meeting and wish everyone well in the meantime. So thank you all for hanging in there with us today.
Thank you.
Thank you.
Bye now.
Bye-bye.